I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to give an introduction to the techniques in peripheral vascular intervention. So, term ischemic nephropathy is commonly applied in patients who have CKD due to atherosclerotic renal artery stenosis. It could be clinically apparent, or there could be increase in serum creatinine. It is seen mostly in patients who have high-grade stenosis of both renal arteries or stenosis of a solitary functioning kidney. Now, what are the features that raise the suspicion of renal artery stenosis? So, it could be hypertension before 30 years of age or starting after 55 years of age. It could be exacerbation of previously well-controlled hypertension, malignant hypertension, which is defined as severe hypertension with signs of end organ damage, which could be like acute renal failure, heart failure, retinal hemorrhages, papilledema, or neurological disturbances. There could be resistant hypertension, which is defined as uncontrolled hypertension despite of 3 or more drugs. Then azotemia shortly after starting ACE inhibitors or angiotensin receptor blockers. Then there could be uncontrolled hypertension with an atrophic kidney, or there could be discrepancy in renal size more than 1.5 centimeters. There could be moderate to severe hypertension and recurrent episodes of acute flash pulmonary edema or unexplained heart failure. There could be a systolic diastolic abdominal bruit or progressive unexplained azotemia. In investigations, you could do a renal duplex ultrasound, an MRA, but remember that in MRA, that's not adequate to visualize the middle and distal portions of the renal artery, which are typically affected in fibromuscular dysplasia. You could do a CT contrast angiography or DSA renal angiography. Now remember, DSA is the gold standard for the diagnosis of renal artery stenosis. For clinical significance of the arterial lesion, you could do an ACE inhibitor scan or captopril renogram, or you can also have a renal vein renin measurement. Now this is extremely important. What are the indications for renal artery stenosis revascularization? So it could be accelerated, refractory or malignant hypertension. It could be renal artery stenosis which is bilateral or stenosis in a solitary kidney, and this is a class 2A indication. But if you have both kidneys and there is a unilateral renal artery stenosis, then it's a class 2B indication to revascularize. Flash pulmonary edema is a class 1 indication, unstable angina is class 2A indication. These are the main indications. What is the angiographic criteria to say that this renal artery stenosis is significant? So it's either more than 75% stenosis or a stenosis around 50% with post-stenotic dilatation. Or if the lesion is moderate, say around 50 to 75% stenosed, then you can either do an FFR, and it will be significant if the value is less than equal to 0.80, or you can do a peak to peak gradient. So it's a peak translesional gradient that's more than 20 millimeters of mercury, or mean translesional gradient of more than 10 millimeters of mercury. That means that moderate lesion is functionally significant. I think important take-home message in the indications for revascularization is that revascularization in the setting of unilateral renal artery stenosis is not supported by conclusive scientific literature except in situations of renal salvage. So, unilateral renal artery stenosis, you will not intervene unless it's a situation of renal salvage. Then renal artery revascularization should not be performed in the setting of an incidental finding of renal artery stenosis during angiography. And lastly, most patients with unilateral renal artery stenosis can achieve goal blood pressures with antihypertensive drug therapy. What's the natural history of renal artery stenosis? So rate of progression correlates with initial degree of stenosis. 50 to 75% stenosis, these patients 10% progressed over 12 months to complete occlusion. And if the patients had more than 75% renal artery stenosis, then 39% progressed over 12 months to complete occlusion. Again, important to know that 90% of these cases are caused by atherosclerotic vascular disease, which involves the ostia of the renal artery and the abdominal aorta, and therefore we also call it aorto-osteal disease. When it's atherosclerotic renal artery stenosis and you want to stent it, you always say start the stent hanging slightly within the aorta rather than just starting from the ostium, because you don't want to miss the ostium, as this is actually aorto-osteal disease. So treatment for atherosclerotic disease, when you want to intervene or needed to intervene, is stenting, and if it's otherwise fibromuscular dysplasia or aortitis, then cutting balloon or POBA usually is sufficient. Coming to the interventional aspects, so you can go either by femoral approach or brachial approach. So femoral approach, some prefer the contralateral femoral because the angle becomes such to engage the renal arteries that it becomes easier from the contralateral approach. If you need to go brachial, when would that be required? When there is a caudal takeoff of the renal artery, so coming from the top makes it easy to engage the renal artery. Or there is an issue with the femoral access like severe bilateral aortoiliac disease, or there is an infrarenal abdominal aortic aneurysm. Which catheters can be used? You can use IMA catheter, you can use JR4, hockey stick, or Cobra catheters. And then there are dedicated renal catheters as well. Which are the best projections to look at renal arteries? Their ostia and stenosis. So it could be LEO20, REO20, or AP. These three are the best views. So when you wire the renal artery, the best is that you stay within the main branch of the renal artery, and the 014 wire does not go right up to the renal cortex. You keep your wire slightly away from the renal cortex. The other thing is, if you need hydrophilic wires to cross the stenosis, then best is to use an over the wire balloon or a micro catheter to change it to a workhorse wire to keep things safe. The renal arteries are usually located near the junction of the first and second lumbar vertebral bodies. So how do you identify them? The 12th thoracic vertebra is identified by its attached ribs, and from there onward you start counting first lumbar, second lumbar vertebra. In figure B, in the middle figure, you can see that the pigtail head is placed near the L1 L2 junction, so that a high pressure injection of contrast will reflect a few centimeters above that level. And in C, you can see that the aortogram demonstrates the origin of renal arteries. This is a 56-year-old lady with resistant hypertension. She presented to me in 2017. This is the aortogram showing bilateral critical ostial renal artery stenosis. This is the DSA, on which you can clearly see bilateral renal artery stenosis. So there are different ways of approaching the renal artery stenosis. One is the no-touch technique. This is the most commonly used technique, in which what you do is you take your guide catheter close to the ostium of the renal artery, but you do not directly engage into it. Rather, you put a 035 wire or an 014 wire into the descending aorta, so that it keeps it away from deeply engaging the renal artery, and then you take another 014 wire, and through that you perform the whole intervention without directly engaging the ostium. So this way you protect the renal arteries or the kidneys by not touching the plaque directly, by not lifting the plaque, or by causing embolization of the plaque material towards the renal arteries. So this is a diagrammatic representation of how renal artery angioplasty is done. So you've taken a guide catheter. In the first picture you can see that, and there's a wire, 035 glide wire, hanging into the aorta, so that the guide catheter does not engage the ostium directly. Another 014 wire is taken into the renal arteries. You usually keep a small bend at the distal end of the tip, so that you do not cause any perforation or bleed in the renal arteries. And then you do not also go very deep with your wire. On top of the wire you can see a balloon coming in. So it's an aorto-osteal disease. You balloon it here, you predilate, then you take your stent in, and you keep hanging your stent a millimeter, 2 millimeter in the aorta, because what you don't want to do is miss the osteal disease, because this is aorto-osteal disease, atherosclerotic disease. Ostium must not be missed. So hang the stent slightly into the aorta, 1 or 2 millimeters, and then you inflate and deploy your stent. Be careful with your inflation. If the patient starts complaining of pain, you need to stop there. Usually that's a lot of stretch coming on, so we do not go much beyond the point of pain. The other thing is, you do not stent long all the way into the distal renal artery, because you need to leave the space for vascular surgeons to put their grafts in case they are required. Like we do for Lima graft in the LAD, you do not put your stent in the LAD at a place where the graft insertion has to take place. Similarly, this is what we do here. And usually the size of the stents are something between 4 to 7 millimeters in diameter, and the length could vary from 12 millimeter to 18 millimeter. Um, Different companies, all the major FDA approved companies are bringing their stents, and they are all available in Pakistan. So coming back to our case, the intervention has started and we are doing the no touch technique. You can see an O35 wire in the aorta and an O14 wire in the right renal artery. This is showing the same thing in a diagrammatic way. This is the approach that I've already explained. So now the next thing, you bring in a 4 by 15 millimeter. This is a coronary non-compliant balloon that we brought. So you inflate slowly 1 atm per 3 to 4 seconds and watch as the lesion is being modified at maximum pressure of 8 to 10 atm or whatever the nominal pressure is. But remember, stop inflation as the patient feels pain and check for any dissection or renal artery rupture. Without pre-dilatation, stent may not open fully, and that's a more difficult situation to deal with. So remember that starting with small balloon, pre-dilatation is done with a balloon 1 millimeter smaller than reference diameter of normal renal segment. That's the policy you can adopt. Generally, balloons 3.5 to 4 millimeter in diameter and 8 to 15 millimeter in length are commonly used. Direct stenting is a possibility for the majority of lesions, but sometimes pre-dilatation is needed. 1.5 to 2.5 and 15 to 20 millimeter inflation as nominal pressure are usually sufficient for advancement of the stent in cases of very tight stenosis. But I will show you a case later where inadequate pre-dilatation led to a difficult situation where the stent was now deployed and would not inflate properly, would not open properly, and it became a nightmare. So always prepare the vessel bed properly, adequately, and then bring in the stent. This is Herculink 6 by 15 millimeter stent from Abbott Vascular. So this is the inflation. So you can see that balloon expandable stents usually in diameters of 5 to 7 millimeter, and as I explained, lengths of 8 to 20 millimeter or 16, 18 millimeters are commonly used. The proximal stent may have to extend back into the aorta by 1 to 2 millimeter to achieve full circumferential coverage of the renal ostium. Self-expanding stents have been used to treat mid-segment lesions but are not recommended for ostial or proximal renal artery lesions. Next, we flare the ostial portion of the stent at high pressure with the same stent balloon. This is the final DSA run of the right renal artery. Then we move on to the left side. The same procedure is repeated. We've taken the same 4 by 15 millimeter balloon to predilate this lesion. Then we move on with the same with another Abbott Vascular Herculink 6 by 15 millimeter stent. We deploy it in the aorto-ostial position, and now this is the final DSA run of this patient. This is the pre and post intervention picture for your comparison, and the result looks pretty satisfying. This is a CT of the same patient done a little later. I don't remember for what purpose we did that, but you can very nicely see the aorto-ostial coverage of both stents. This patient remained fine for almost 5 years. She was in my constant follow-up. But November 2022, she again presented with uncontrolled hypertension and slightly impaired renal functions. Doppler ultrasound suggested bilateral critical ISR leading to bilateral renal artery stenosis. At that time, we had some limitation of existing inventory. The largest cutting balloon that was available was 3 millimeter by 15 millimeter Wolverine. The largest drug coated balloon available was 3.5 millimeter Sequent Please Neo, and the largest non-compliant balloon available was a 5 by 20 millimeter NC track. So we had a lot of limitation with diameters of the devices. So in this patient, we took the femoral approach with 6 French JR 3.5 guide catheter. You can see the critical ISR. So we've taken a 014 workhorse wire for the coronaries, and this is a Wolverine 3 by 15 millimeter cutting balloon. Now, under normal circumstances, what you do is you pre-dilate as much as you want to with the largest size balloon, and then you give the final treatment with your drug-coated balloon. Here, my problem was that I have a 5 millimeter balloon to pre-dilate the stent, but then my final therapy with the drug-coated balloon, the balloon size is only 3.5 millimeter. So I've seen some interventional radiologists and vascular surgeons do this strategy in peripheral interventions in USA, that they would apply the drug first and then use their bigger size balloon because they didn't have a bigger size drug coated balloon. So this is exactly what I did here. So I've used the 3.5 millimeter drug coated balloon to apply the drug, and then I've used a 5 by 20 millimeter NC track balloon to open the stent as much as possible. Now this is the maximum we could do with the available inventory, but at least we've established good flow on this side. Then we moved on to the right side. You can see that the critical ISR here, we've wired it with a 014 wire, and you can see that the used Wolverine balloon cannot enter the stent because the wire is probably behind the stent. So we need to rewire it. This is a rewiring attempt that you can see. So finally this 014 wire goes through. Yes, it's in place, and now the same Wolverine balloon, you can see it's a used one, but how smoothly it comes in. So whenever the inventory is not entering, we need to rewire. Always think that the wire might have gone behind the stent. So this is done, the cutting balloon is done. So we use the same drug coated balloon strategy on this side, but unfortunately our 3.5 millimeter balloon was only available in 35 millimeter length now. So that's the length that we've used, but it does not matter because it's hanging in the aorta and it's just a 3.5 millimeter balloon, so it's not touching the walls really. Next, we dilate the stent with the same 5 by 20 millimeter NC track balloon. And this is the final result. Looks much better on the right side as compared to the left, but still left also has good flow as seen here. This is another case which was done through radial approach because you get more pushability when coming from above, especially depending on the angle of the renal artery origin. 035 wire again to avoid aortic scrapping and dissection with injection, and also prevents thromboembolism in lumbar arteries or the lower limbs. So this is the no touch technique. Then again BMW 0.014 wire. Then the 035 wire is removed, and we engage the catheter. So the first step before doing selective renal injection is to backbleed or aspirate your catheter to remove all debris that accumulated during the engagement of the renal arteries. This prevents further damage to the kidneys. You can use an FFR if any doubt about the severity. Again, we do dual antiplatelet therapy for these patients, Plavix for 30 days, aspirin lifelong. You give heparin during the procedure. Usually 5,000 international units heparin are sufficient enough. So this procedure is done. And remember, when you size the stent, do not size the stent according to the post-stenotic dilatation, because that way you will oversize the stent. This is a case of Professor Thomas Zeller, with whom I worked in renal artery stenting in Bad Kreuznach, Germany. And he's also written a chapter of renal artery stenting in the EuroPCR book. So in this case, the left renal artery had critical osteal stenosis. There's eccentric calcium that is seen in the ostia. They did direct stenting with a 6 millimeter stent. Stent balloon pressure taken up to 16 atm, that was the rated burst pressure, but they did not go beyond this to avoid stent edge dissection. This is something that we need to be careful with. They used a 5 millimeter non-compliant balloon. It had no effect. You can see the big waste there. They used 3.5 millimeter OPNC balloon up to 40 atmosphere pressure, no effect. They used two parallel 2.5 millimeter OPNC balloons, tried, but they could not expand any further, and they finished it with a 3 millimeter drug coated balloon, and this is the final result for it. So you can see that if you do not predilate adequately, this kind of thing can happen, and this is something that you cannot really deal with because later on these parallel OPNC balloons, this was a risky maneuver. The artery can burst, and this is in very experienced hands what happened. The next patient is a 61-year-old male post-renal transplant presented with worsening graft function and uncontrolled hypertension. Renal Doppler documented a peak velocity of more than 4 meters per second. So, stenosis in transplant renal arteries can manifest as graft dysfunction or resistant hypertension. And percutaneous revascularization has become preferred management given the complexity of reoperation. So, in this patient, what we did was we deployed a 4 by 38 millimeter resolute onyx stent, and now you can see this is the final result. It's a relatively safe procedure. You've got the access site complications as always. Arterial main branch complications, 2 to 5% chances of dissection, occlusion, thrombosis, rupture, perforation. Then there's a possibility of contrast nephropathy, renal insufficiency, renal failure, perirenal hematomas. You need to be careful with your wire handling. Renal infarction, which presents as flank pain or hematuria, atheroembolism, because of which, in order to prevent that, you are using the no-touch technique. And then 2% cases may require surgical salvage and secondary nephrectomy. There could be deterioration of renal functions after renal artery stenosis. In the first 1 or 2 days, that's usually due to contrast medium. In 3 to 8 weeks, it's because of atheroembolism, and in 3 to 6 months, it's mostly restenosis. The worst complications could be rupture and perforation of the renal artery. That could present as back pain or abdominal pain or sudden hypotension, so we need to keep an eye on that. If it's a distal branch perforation, you can use balloon tamponade, reversal of anticoagulation, you can do coiling or PVA particles. In the main branch, if there's a perforation, you can use balloon tamponade or covered stent. So the first renal artery balloon angioplasty was done by Andreas Grunzig in Zurich in 1977. For atherosclerotic renal artery stenosis, stenting is the therapy of choice with annual ISR rates of about 10% with current devices. You must remember that renal arteries with a diameter of 5 mm or less have 20% risk of ISR with bare metal stents and should get a drug-eluting stent. And ISR is then treated with restenting and angioplasty or drug-coated balloons that are now available. There is no point in revascularization if the kidney size is now less than 9 centimeters or the serum creatinine has gone above 4 milligrams per deciliter. But the contraindications to renal artery stenting mainly are very calcified aorto-ostial lesion. We've seen the example in a case before. Then artery less than 4 millimeter in diameter because of the high rate of ISR. And then if your stent is going to jail a side branch, that's not a good idea. Or the stent is landing at the surgical site, which you need to leave alone for the surgeons in case grafting is required at a later stage or there is presence of sepsis. Now, surgical revascularization is recommended if angioplasty fails or in the presence of multiple small renal arteries or aortic disease. Just a few, rather 2 slides about fibromuscular dysplasia. 10% of all cases of renal artery stenosis are due to fibromuscular dysplasia, and 90% mainly the bulk is with atherosclerotic disease. Now, FMD affects the 3 layers of arterial wall. It's mainly affecting the younger women. The classic sign is a strings of bead appearance that I'll show you in the next slide. Middle and distal portions of the artery are the most common locations, and then the main treatment is balloon angioplasty. You use a stent only when there is suboptimal result with POBA or there's a flow limiting dissection. Surgical revascularization is usually reserved for patients who have failed percutaneous angioplasty or whose anatomy is not amenable to percutaneous angioplasty. This is the classic appearance of fibromuscular dysplasia, and the lower picture is showing after balloon angioplasty the final result. So balloon angioplasty is mostly used for this. Now what we must remember is that if the patient has FMD in one vascular bed, they frequently have FMD including aneurysms and dissections in other vascular beds and therefore should undergo CTA or MRA.